This topic here, Introduction to Dental Sleep Medicine, is designed to kind of give you an overview, synopsis of what a dental sleep practice might look like within the parameters of your patient care. The idea is here to kind of get you to see why we as dentists should start taking an active role in trying to be part of screening and as well as managing some of these patients that present with some form of a sleep breathing disorder. The first thing I'd like to start off with is the fact that there's just so much awareness. Awareness is something that's been hitting the medias, both in the print format, both on the internet, news feeds such as the Today Show, some of the late night television shows. But more importantly, it's also coming into sitcom. There's an episode of Mike and Molly talking about Mike having a CPAP and Molly struggling to deal with the noise that is generated from the machine itself. So what's happening right now is there's more awareness of sleep, and not just sleep in general, but also sleep apnea, where there's a cessation of breathing that takes place with these individuals that fall asleep, and we'll talk a little bit about that here shortly. So what was a struggle maybe 5-10 years ago when it came to educating patients now seems to not to be as much of a challenge, because they've already heard about sleep in different formats, and it's just a matter of them understanding why a dentist has a significant interest or how they can actually help facilitate identifying these individuals and, as mentioned earlier, managing them. So if we look at some papers, the biggest problem we have, unfortunately, is the inability to recognize risk for sleep apnea. Now, no fault to the profession per se, but we also have to take into consideration that sleep's a relatively young field. And most of us that graduated back in the 70s, 80s, 90s, and maybe the early 2000s had very little exposure when it came to sleep-related issues in dental school or dental training, and even in dental hygiene programs. But newer schools, newer programs, newer deans, newer curriculums, there is some push now for some level of dental sleep medicine education, both in the dental programs as well as the dental hygiene programs. So we would probably see the future dentists coming out of school a lot more versed than what our predecessors have gone through. So what is this whole thing about sleep, and what is normal versus a situation where someone may be an apneic breather? So if you look at the cartoon on the left, this right here will represent normal breathing, where you have the nasopharynx, oropharynx pretty much wide open. In other words, there's no obstruction that takes place. Air flows into the nose, back to the nose, back in the back of the throat, and then down into the trachea, into the lungs. This is normal breathing. This is healthy, normal breathing. And apneic is a situation where there's some changes that have occurred. One in particular, either there's an extension of the soft palate, maybe there's an excessively large tongue, or the jaw is a little retrognathic by nature, which encourages some degree of blockage. So in an apneic breather, what happens is you have the tendency of breathing the air through, but because of this physical obstruction, you're unable to pass this air through the lungs. Okay, and this is what we are trying to identify. These patients that are apneic breathers that may potentially have the problem purely by our dental examinations. I'll spend some time discussing what these features might look like. So what is the prevalence of possibly having obstructive sleep apnea? And when I use the obstructive sleep apnea, what it basically means is individuals that stop breathing for about 10 seconds in their sleep, which leads to some reduction in oxygen level in their blood, which also then is followed by the fact that the brain wakes up, or what we describe it as an arousal. So if you can picture yourself sleeping, and if you have 10 events or 10 apneic events per hour, think of it this way. You go to bed and some little kid comes in and wakes you up, comes back in your room and wakes you up, and does that 10 times per hour. How would you feel after 6 to 8 hours of sleeping as far as how your mood, your temper, and how refreshed you might feel? So these disruptions in sleep would lead to fatigue, lead to all these other comorbidities that are associated with not adequately breathing at night. So in men, it's estimated that 24% have this condition, and in females, it's approximately 9%. Where it does get interesting is if I ask patients, are you tired? Are you fatigued? And have signs to suggest that they have sleep apnea, then you're only picking up about 4% of men and 2% females on the merit of them being tired. So do you understand? You don't necessarily have to be tired to have this condition, because the majority of patients may not express the symptoms of being fatigued or tired. And that's a very important point, as I will hopefully tie into towards the end of this presentation. So what's the function of sleep? Ultimately, why do we even bother sleeping? Well, the first thing that's been hypothesized is fatigue reversal, and we've all experienced this. If we've had a series of nights where we've not slept well, the 5th, 6th, 7th night, and we have the ability to get some deep sleep, we wake up feeling refreshed. We feel like Superman at some point. This is because of the ability to recover and re-energize. And we need to have adequate sleep with adequate ventilation that leads us to have fatigue reversal. On the other hand, there's also a biochemical refreshment that takes place. Do you understand? There's a lot of neurohormones, there's a lot of enzymes, a lot of factors that need to be refreshed as a result of the day-to-day activity. So most of this refreshment activity, biologically speaking, occurs during various stages of sleep. It also helps support our immune function. And I think we've all experienced this. If we've not had a good night's rest, and we do this for a series of nights, it's very common for you to catch the cold or catch some bug. And the reason for that is suppression of the immune system. So we do know that sleep has some protective role, and it allows us to reset our immune function to help us with fighting the bugs that we deal with every day. Memory consolidation. Now, everything I'm saying today will only stick if you happen to get a good night's rest. What you learn in the daytime, the way you consolidate that and put it into memory is going through the deep sleep stages as well as the REM stages of sleep, where we have dreaming that takes place and things of that sort. In those stages is where we actually park the information we learned during the day and allow us to improve our memory. And ultimately, it's our psychological well-being. I'm sure you can once again respect the fact that if you've had a few nights where you've not slept well, your temper is short. You might be more angrier. Your tolerance level has definitely changed. Therefore, your psychological well-being definitely is affected with poor sleep. So we need to be able to sleep well, sleep long enough, which is adequately determined based on your age, as well as wake up with good oxygenation, leading us to have better function the next morning. This is a cartoon summary just to kind of highlight those points that I just mentioned. The various stages of sleep, such as stage 1, as illustrated here, there's a couple things that happen. Now, stage 1 is where we're just getting ready to fall asleep, and we've all experienced a situation where you're laying in bed and you're kind of aware of the environment, but you're also kind of not completely aware, and then you have some form of a jerk that takes place. Your hang flings, your leg kicks, and these are what we call hypnic jerks. That's strongly suggestive that you're in stage 1 sleep. Once you pass that stage and you go into stage 2 sleep, there's a lot of other things that take place. In this situation, there's a change in breathing patterns, there's a change in body temperature, loss of sense of where you are, slower brain activity, and your eye movement stops. As we progress further, we get into stage 3 sleep, and with stage 3 sleep, there's a lot of other physiological process that takes place. What I like to emphasize with stage 3 sleep is this right here: tissue grows and repairs. You need stage 3 sleep to be able to restore yourself. In other words, in stage 3 sleep is where you actually release hormones to help you function and also allow you to repair your body from the day-to-day activity. And then finally, REM sleep. This is where your brain is active. This is basically where most of your vivid dreaming takes place. And there's a lot of other parameters that actually occur in REM sleep. So when we sleep, we have to go through these various stages of sleep. You start with 1, follow through into 2, 3, and then REM. And then you bounce back into possibly 2, a little bit of 3, and REM. As the night progresses, the shallower stages get shorter, but REM sleep actually increases. So there's a lot of physiological aspects that need to take place in sleep for us to be able to restore ourselves. So what about dentistry? I mean, where are we as far as educating the dentist? AGD Impact, some years back in March 2009, dedicated this whole journal to breathing easier, basically exposing dentists on the topic of dental sleep medicine. And then they repeated that again back in June 2014. But there's also other publications that have done a very similar effort in trying to devote the entire journal to the topic of sleep. So there is literature out there, there is the awareness that's taking place. Now it's just a matter of us being able to identify these patients. So what are some of the clinical indicators that we should be looking for? Well, first of all, is basically signs and symptoms. The most common symptom, or if you want to use it from another perspective, complaint, is with snoring. Snoring would suggest that there's a narrowed airway, but doesn't tell you anything more than that. Snoring does need to be explored prior to determining whether an oral appliance needs to be facilitated. So if you have a patient who says, hey doc, the only thing I do is snore, well, you know what, that's great. But what I can't ascertain is whether or not you breathe appropriately at night. So doing a snore guard without really having a true diagnosis of them just being a snorer and not possibly an apneic is something that you want to take into consideration, because one of the signs and symptoms for obstructive sleep apnea is definitely snoring. The other is excessive daytime sleepiness, the feeling of being unrefreshed, choking or gasping during sleep. That's typically noted by the bed partner. On a few instances, the patient may wake up themselves, the individual will wake up and say, wow, you know, I was choking, or I was coughing, or my heart rate increased. And the reason for that is they were probably choking, got enough of an arousal to wake themselves up and kind of be aware of this type of response that's taking place, which is a strong suggestion that the person is stopping breathing during sleep. The other would be fatigue, lethargy, depression, and in some instances, morning headaches. So these are things that patients may talk to you about. Now, from a dental standpoint, we do have the ability to see patients that may complain of morning headaches. And many times we may jump the gun and suggest that it might be due to grinding or clenching the teeth, and that is possible. But what we also have to keep in the back of our mind that is it possible that it's the fact that they aren't breathing well at night, and as a response to having high levels of carbon dioxide, it itself triggering a headache. Now, most common risk factors, of course, weight. If you put on weight, not only do you have weight in the abdominal area, but you also will have a weight increase in your neck circumference will change. So that's something we need to take into consideration, obesity being a common risk factor. Male gender, up to the point when females have menopause. When females go to menopause, the risk in females dramatically then increases as well. Craniofacial abnormalities, abnormal upper anatomy, these are areas that you and I spend so much time looking at, which is why we're in a very tuned area in finding these individuals purely based on craniofacial abnormalities and, of course, the anatomical narrowing of the upper airway. Comorbid conditions could be from a health history form, genetic. If mom or dad has apnea, there's a good chance the kid's going to have apnea. At the same token, if the kid is what gets diagnosed as having apnea, then there's a good chance that one of the parents or both the parents may possibly even have apnea. And then, of course, logical things, environmental factors. I think we've all experienced this. You have a little too much to drink. That night, you're told you're snoring a lot more. You may go out with your buddies to the cigar bar, smoke for a period of time. You have edema in the back of your throat. You're going to snore a little bit more. So we know there's environmental factors that can also affect the dynamics of the upper airway. And let's not forget sedatives, hypnotics, and also we should take into consideration narcotics for chronic pain management as potential risk factors for this condition. So where do we stand? I mean, a lot of times this is what we look at day in and day out. We look at the maxilla, we look at the mandible, but there's clues within those areas. There's clues with the maxilla, the teeth themselves will give you a story, the soft palate, the tongue, and also any bony deposition that you might find on the maxilla and or the mandible. So what are some of these things that we should probably be looking for? Well, one could just be simple cervical abfractions, or what's also described as non-carious cervical lesions. These are these notchings that you find on specific teeth, not typically generalized, it's more isolated. The argument is that a lot of times the practitioners may jump to the conclusion that the person is brushing too hard, hence therefore the cervical abfractions. Well, that being said, you gotta be cautious that are these the only teeth that they're brushing? So normally when you have cervical abfractions that's isolated, it's possibly due to clenching. Retrognathic mandibles, class 2 bites, things of that sort would also increase the risk of sleep disordered breathing. We should also respect the fact, not always the case, but respect the fact that if you have smaller dental arches, and typically that could be a result of bicuspid extractions. Now what you have there is the fact that the arches are small, but the tongue was never proportionally reduced to fit that small box. So if you have crowding, and we have to remove a series of teeth to basically unwind the crowding, then I think it's only fair to cut some of the tongue away so it fits within that box. Well, that doesn't typically happen. So as the individual ages and as the individual loses muscle tone, there's a high vulnerability of potential collapse that may increase the risk of sleep disorder breathing. There's enough evidence to support that a vaulted palate is a strong contributor for sleep disorder breathing. The mere fact of seeing signs of bruxism in some instances may contribute to the fact that the individual has some level of sleep disorder breathing. Large tonsils, which also once again obstructs the airway, is a sign that would suggest some level of apnea. Something that we see all the time in the practice is lateral tongue scalloping. And the argument is, what is lateral tongue scalloping? And ultimately what it is a large tongue within a small confinement of space. It's like putting a tight watch on. And when you take the watch off, you have a band print of your watch. Well, here's a band print of your teeth, suggesting that there's not adequate width for your tongue. Once again, increasing the risk of sleep disorder breathing. And then any bony depositions, in many instances, is the torides. The torides can be suggestive of possibly a history of clenching. But there again, a tori also occupies and takes away tongue space, which can therefore lead to an increased risk of sleep disorder breathing. So these are some of the most common features that you might see in a clinical setting, clinical practice setting, which should bring your awareness up to suspecting that the patient may have some form of a sleep disorder breathing situation that may need to be further investigated. So we talked about apneic breathing earlier, and we talked about the fact that there's some level of obstruction that may take place in the back of the nose, described as the nasopharynx, or the back of their tongue, which is the oropharynx. In some instances, a combination of both. So what I want you to see is this little video that shows a person being studied in a sleep laboratory, but actually shows you what an event kind of looks like. So the snoring was a narrowed airway, and from this period on, he's extremely quiet, but pay attention to his abdomen and his thorax, and you'll see that there'll be a rhythmic activity that takes place. Because what's happening up at the throat, there's a blockage that's occurred. So there's no airflow, hence there's no noise. But the diaphragm is trying to pull air, and you'll see an increase in the rhythmic pattern as it's trying to draw the air past the obstruction. Now, if we had a pulse oximeter on him, and here he's woken back up to get his next breath. If we had a pulse oximeter on him, in that period of time when he had stopped breathing, you'd start seeing a declining oxygen level. He hits a threshold where there's enough of a stimulus that an arousal kicks in, where the brain is awoken. When the brain wakes up, muscle tone is restored, airflow resumes itself, and then this whole cycle repeats itself. The first episode you looked at was a 34-second cessation of breathing before he woke up to get his next breath. So to give you an idea of what an apneic is, to have an apneic event, it's basically measured on the fact that you stop breathing for at least 10 seconds to be considered as one event. All right, so how do you screen for some of these patients? Well, one way is to basically use some form of questionnaires, and we'll talk about some of the most common questionnaires. The most common one utilized in a medical setting as well as in a dental setting is the Epworth Sleepiness Scale. What this questionnaire basically does is assesses how fatigued the individual might be. Now, mentioned earlier, 24% of men, 9% of female may have this condition, but only 4% will complain of being fatigued, and only 2% in females will complain of being fatigued. Hence, therefore, if this questionnaire gets filled out and the numbers are not high, but clinically there's enough parameters to support that they may have some level of obstruction, go with the clinical finding rather than the questionnaire. Remember, the questionnaire is looking for patients that might have some level of fatigue. So the questions are 8 scenarios: sitting and reading, watching television, sitting inactive in a public place, as a passenger in the car for an hour without a break, laying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol, and in the car while stopped for a few minutes in traffic. And out of these 8 scenarios, they ask you to score that on a 0 to 3 scale, with never dose being a 0 and 3 being a high chance of dosing. And for every one of those questions, you would have the patients put a numerical value. You will tally up the numerical value, and if it scores greater than 11, then it's strongly suggestive of some level of fatigue. Doesn't necessarily equate to the fact that the patient may have some form of a sleep-eating disorder, but it does definitely equate that some further investigation is necessary. Another questionnaire that's easy to use is called the STOP questionnaire. 4 questions. S, do you snore? T, are you tired? O, has anybody observed that you stop breathing? And P, do you have a history of hypertension? 2 or more yeses to this increases the likelihood of them having some level of obstructive sleep apnea. There's another portion of this called the STOP BANG with 4 additional questions, the B being body mass index above 28, age over the age of 50, and neck circumference. For men, greater than 17, and for females, greater than 16. And G, are you a male gender? The more yeses to the second half, the higher the likelihood that the person may have mild to moderate sleep apnea. So by just asking 8 questions, you can ascertain a good level of potential risk that the patient may have some level of a sleep-eating disorder. Now, you can also do this by just identifying patients in your hygiene setting. And this is where a screening questionnaire might be utilized. And of course, getting the hygienist and the dentist to understand some of the risk factors for sleep disorder breathing. Now, that being said, we do not make a diagnosis. What we can do is identify patients and make a referral for diagnosis. So I want you to be extremely clear on this point. Our job is to identify potential patients. We don't even tell the patients they have apnea because we don't know what they have. What they have is the fact that we suspect that they have some form of a sleep breathing disorder. The referrals made to your medical colleagues. They will then determine whether testing is warranted, and if testing is conducted, they'll share the results with you, and then accordingly, you can proceed with whatever process you may have in your office. But you know what? That's looking for patients. What about patients you already have that already have been diagnosed but don't know that there's a dental solution to the problem? And this is where some form of either communication, posters, signs, to advise to educate your patients that, hey, if you are non-compliant to your traditional therapy for sleep-breathing disorder, you may have other options. Speak to the dentist, speak to the hygienist, speak to the office staff. So putting some form of collateral to make your patients aware is not a bad thing. All right, so risk factors for sleep disorder breathing that you might find in a hygiene practice is, look, the age, the gender, the BMI, and the health history form. And now we can factor all these variables in, but I do want to mention one thing. As we age, we lose muscle tone. As a result of losing upper airway muscle tone, we have a higher propensity of the airway to collapse. But what's important is the health history questionnaire that all our patients fill. So if we look at the health history questionnaire, there's a lot of things we can home into. And I've got a few things listed on the left-hand side that may strongly support and suggest that the patient may have a comorbid condition with these conditions that could potentially be obstructive sleep apnea. And if we look at this statistically, if someone indicates that they have a history of congestive heart failure, then there's a good chance, 60%, that they possibly have obstructive sleep apnea. If they've mentioned that they've had a stroke or a trans-ischemic attack, then there's a good chance that 70% of those patients already have sleep apnea. Type 2 diabetics, 65%. Drug resistance hypertension, which means they take more than 2 blood pressure medications to control their blood pressure, there's an 83% chance that they actually have this condition. Hypertension by itself is at 37, and coronary artery disease at 30. How many times a day do we have patients that are on antihypertensive drugs as well as our diabetics? Just looking at those 2 number sets, there's your patients as far as screening your patients. These are the patients you may want to educate, and these might be the patients you want to refer to be tested. So what's modern day treatment for obstructive sleep apnea? Well, from the medical intervention, you've got CPAP therapy, which is basically room air that's pressurized and blown either through the mouth, the nose, or a combination of both, depending on the type of mask the individual wears. Or there may be the surgical intervention, where they actually will go back in the back of their throat, remove the tonsils, remove the uvula, trim some of the soft palate to open up the nasopharynx and improve airflow. From a dental standpoint, we have some options as well. We have the oral appliances, or the mandibular advancement splints, or mandibular advancement devices, or what's also described as the oral appliance therapy, abbreviated as OAT. You also have palatal expansion that can be utilized in pediatrics, in children that have airway issues, where it's purely a matter of developing the upper airway through orthodontics and expansion. And then, of course, there's lifestyle changes. One being, is it possible that the person only has more events of not breathing when they're on their back? The solution might be is to put them on some form of body positional therapy, where they're actually off to their side. Smoking, modifying smoking, losing some weight. And these are some of the other lifestyle changes that one may want to incorporate when it comes to treatment for these conditions. So you think you all might be familiar with this move. Everybody calls it differently, but what this is the jaw thrust maneuver, typically performed when someone hits the ground. Quickest way to open up the airway is to take the mandible, bring it forward, or jaw thrust it. Well, here's what's interesting. We do this when someone passes out or hits the ground to open up the airway. So if you have an apneic, would it not be wise to do a procedure as such during sleep to keep the airway open? And that's exactly what oral appliances do. So if you look at it from a perspective of CPAP therapy, what CPAP does has a tendency of blowing the air into the nasopharynx in this example, past the obstruction and getting it down to the trachea. So here you have a pneumatic kind of a split that keeps the airway open. And oral appliance, on the other hand, moves the mandible forward. So by moving the mandible forward, we physically bring the tongue forward as well. There again, opening up the oropharynx, nasopharynx through the mere fact of repositioning the mandible. So you can get a sense of what the treatment is. One is we blow the air past the obstruction, and the other is we move the obstruction. So, like I mentioned, that jaw thrust maneuver, well, here's devices that do exactly the same thing. You could maybe have your bed partner stay up all night and jaw thrust you so that you can sleep well. Not too sure how your bed partner's sleep would be. Or place one of these if you can't tolerate CPAP and let the mandible be held forward while you sleep to try and keep the oropharynx, nasopharynx open and clear for you. So let's take a look from a snapshot perspective of what this whole dental sleep medicine flow might look like within a practice setting. So these are the steps we'll cover. I won't let you labor the point on this, but we'll spend some time on every one of these steps so you have a better understanding on how this plays out. The first and foremost is possibly the initial phone call. This is where you would probably have developed relationships. Maybe you have done social media marketing, whatever it is to get the phones to ring. And this is where you want to basically educate the patients. If anything, bring them into the office so you can at least screen them, see if they're even a potential candidate for oral appliance therapy. But most importantly, this gives you the option of giving them an oral appliance for them to ponder on, hold, validate, visualize, and get a sense of how little the product might be to help facilitate the airway. The key thing is not to say too much on the telephone. The key thing is to get them through the door. You may have your insurance discussion, and we'll labor that point at some point. You may want them to bring a sleep study with them so you can review it with them and have an understanding of what it is that you're going to have to be challenged with. And if possible, bring a loved one, because a lot of times a bed partner comment about the individual sleep will give you a lot of clues as far as what you're dealing with. Now, your office visit, this is where you're going to screen your individuals, kind of get a sense of what's going on with them and see if there's anything that's going to work against you as far as treating them. This is where you may schedule them based on how efficient you feel or how competent you feel, anywhere between 15 to 60 minutes. Your assistant will verify that the paperwork has been completed effectively, review the paperwork, review the chief complaints, look over the medical history, and then kind of get a sense of why they're really there. You would step in, you'll go through your examination, you'll review the findings of the examination, you may discuss the sleep study and what it actually means to them, and then you want to have an idea of how you may be able to help them. And this is where you may discuss appliance therapy or maybe talk to them about other things that may need to be taken into consideration to help them with their chief complaints. Now, in that process, you're going to do a thorough clinical exam where you're going to look at the head, neck, you look at the tongue, the airway, you look at the palate, intraoral evaluations such as abfractions, maybe narrowed arches, vaulted palates, lateral tongue scalloping, all the things you'll be looking for, tonsils, soft palate, etc., etc., etc. Measure the range of motion to make sure that the mandible does not have any secondary issues that might be prohibitive of doing oral appliance therapy, and then of course palpate the necessary muscles to make sure that they are healthy before you put them in a device. Now, one good product that's out there that will actually help you assimilate a lot of this information is Dental Writer. And you can get more information by visiting dentalwriter.com as far as patient intake forms and exam forms so that you can consolidate the information and be able to generate the necessary paperwork for your referrals, as well as the insurance company to get your claims paid. Listen to the joints. Is there a click? Is there a pop? Kind of get a sense of how healthy the joints might be. And then there again, there's a gamut of things that you would need to be exposed to and understanding as far as doing a comprehensive exam. But what I'm trying to show you here is kind of the steps involved in making this process happen. And then once you gather all this basic necessary information, it actually puts you in a position to be able to kind of answer the necessary questions, but more importantly, make you aware whether the patient is a candidate for treatment. A note of caution here, when it comes to managing patients that have been diagnosed with obstructive sleep apnea, we as dentists basically play the same role as a respiratory therapist might play. In other words, we need to have a physical order from a physician recommending oral appliance therapy. We cannot just proceed with it without some form of documentation. The little RX on the left is from an ENT practice here in Metro Atlanta. They basically wrote, "Oat, oral appliance therapy for sleep, ask dentist." And the one on the right is a custom one that we use and provide to our patients to get them to get that signed before we fit the device in their mouth. So just some little pearls here. For us to be in this industry, we need to basically work with the medical order to fit them with the device. Now, when the examination is determined, this is where the office has some responsibilities. This is where they may need to call to determine benefits. They may need to call to see whether pre-authorization is necessary, or if any additional paperwork is necessary for approval from, interestingly enough, medical insurance, not dental insurance, when it comes to treating these patients. Now, if everything goes well, patients are educated about the benefits and they're happy with it and they want to proceed, they will come back into the office. This is where records will take place. You'll basically take some form of imaging to make sure that everything is healthy from the if it's possible, a panoramic to look at the condyles, or to at least an FMX. Now, you need to get some impressions, and the impressions are basically what you need to send to the laboratory to be able to make these prostheses. But with the impressions, you also need to have a starting position for the lower jaw. And there's many ways, there's many schools of thought as far as how one may go about doing it, and I'll describe one method here shortly. So as I mentioned, you need impressions. You want impressions that can be re-poured. And my recommendation is don't pour your impressions when it comes to fabrication of your sleep appliances. Take a good set of impressions, send it off to the laboratory, let the laboratory pour it, but use a material that can be poured a couple of times, because most labs will have a working model and then a final model to make sure that everything's fitting properly. Now, you could say, and I have used PVS. It is a very good method. But the only thing with PVS is a little bit expensive when you look at the long run associated with it. Allergen is questionable. The thing with allergen, as you know, it needs to be poured up within at least a certain time period so you don't get distortions of your models. And some individuals may take alginates, put it in a Ziploc with a wet damp cloth or a napkin and then ship it off to the lab. I'm not too sure with it. I'm not too sure as far as stability long term. Plus with alginate, you only pour it once, but then the lab would have to duplicate models, which will be an additional charge to you. So in my hands, after doing this for a good period of time, I've actually come to the conclusion of just using Silginate from Catapult. The interesting thing with Silginate is the price point. It's very, very accurate when it comes to getting impressions for both sleep appliances, or in my case, also for appliances for temporomandibular disorders. But the fact is that you can re-pour it multiple times. Most importantly, my bread and butter is impressions when it comes to fitting and managing these patients, which means when I have sat down and looked at numbers and costs associated with taking impressions, it's come down to this consensus that Silginate still outweighs most of the other products that are available on the market. If you are or are not aware, Catapult is basically direct purchase. In other words, you buy from Catapult. With some of the other materials, you have a tendency of buying it through a rep, which also then means there's going to be some degree of markup in the middle. So just some pearls. So we use Catapult, Silginate impression materials. We use disposable trays. I like to use the little standalone unit that dispenses the material. And the picture on the right is to give an example of a good impression. Nothing more than just basically filling the tray and basically setting the tray above the teeth and in a linear manner pushing it up into place, as opposed to rolling it in, which is what we have a tendency of doing with alginate, where we seat the posteriors and then roll the anteriors. With Silginate, to get good impressions, you want to basically superimpose the tray loaded with the material over the arch and then seat it in one uniform motion, straight up on the top, straight down on the bottom, without a rolling effect. And you'll find that you'll get very, very good impressions. Now, you need a bite. And I talked to you about getting a bite. The reason for that bite is so that the laboratory knows where to fabricate this device. There's many methods. The method I'm going to show you quickly, or just basically describe, is this George gauge. George gauge is a way of kind of determining how much vertical you need and also how far forward you need to bring the jaw. Unfortunately, the time is not permissible for me to completely describe this in process, but I would encourage you to take courses on this topic to get some hands-on experience on how to get these bites. But what this bite does, it gives the laboratory the opportunity of mounting those models and fabricating it. Well, we use two different products in the office. We use Futar, which is basically a good fast-setting bite registration material. And many a times I will use actually Patel putty. And I like Patel putty when it comes to bites specifically for sleep appliances, because as you can see, you get some great, good, solid indentations that's not going to really mismount a cast. Not to say you can get the same with Futar, but you need to express more Futar to get just as good indentations in it. So there are two products that we use when it comes to getting a bite registration specifically for these appliances. The staff, they will just go ahead and follow the lab slips as far as a device you may want to utilize for your patients. So here's two examples of two different lab slips that one could utilize when ordering the appliance. Now, the process is done, the impressions are done, the impressions are shipped off with the bite, and now it's time for delivery. The good thing with delivery is most of this is all delegated to your staff, where they'll verify the fit of the appliance, verify that the patient can remove it, seat the appliance, also demonstrate that they have the ability of possibly moving the jaw forward if there's a reason for it, which is advancing the device. Advancing the device would be done where if you've got an appliance and you set it at a certain position, but the patient states that, hey, my snoring has improved, but I still have a little bit of snoring, or I still am a little bit fatigued the next morning, you then have the ability for them to advance the appliance where the jaw will be pushed out a little further to see if it makes any additional improvement. Provide written instructions so they have a clear understanding of how to advance the device. Also, what happens is when they wear a device that brings the jaw forward, there's a tendency the next morning of the bite not coming completely together. And the reason for that is your lateral pterygoid muscles are contracting for the 6 to 8 hours while you're sleeping, which then has a tendency of drawing the mandible forward. So what we do is just give them some tools. One tool is basically demonstrating how to do some jaw exercises in the morning, where they'll bite on a wafer that comes with most of these devices, and that typically resets the muscles so that this bite issue is not a major concern. Once again, also provide written instructions so they can visually see the steps necessary when they get home. Take some pictures. Take some pictures of their bite so that you know where they were when they started. I like to take a frontal, a right lateral, a left lateral, a occlusal upper, a occlusal lower. And I also like to finish up by getting a picture of the appliance in their mouth so I have a memory recall of what device I may have given them when reviewing pictures. Now, this is where it gets interesting, and this is where the services actually get billed under medical. Now, there's a lot of things you need to be aware of with medical billing, but there's a diagnosis code that one needs to have. And the diagnosis code for obstructive sleep apnea is basically G47.33. This is typically given by the physician. So when you get that sleep study, somewhere on that sleep study, there'll be this diagnosis code. The work that you perform or the procedure you do as far as fitting the oral appliance, when you bill that to medical insurance, you would use the E0486 with a -NU to support that it's a new device, not a used device. Now, I don't want to go into too much as far as billing is concerned. What I do want you to do to be exposed to is take a course on medical billing, and you can get these tools and get an understanding of how to utilize medical insurance to perform dental sleep medicine, and in some cases, use it for also restorative procedures when trauma has been associated with it. One great source, once again, is dentalwriter.com. They provide a lot of billing courses for staff and dentists to be attuned to how to bill medical insurance. So keep this in the back of your mind. Now, when the device is billed, the device is typically billed the day you deliver the device. All right, so the day you give the patient the device is the day you actually bill medical insurance. The patient is typically put on a little recall. We like to bring them back between 2 to 4 weeks to make sure that they're doing okay, make sure they have no issues with the device, but also it gives them the opportunity to advance it if there's a reason to do so, so they can get to the point of subjective improvement. At that follow-up appointment, which might be 2 to 4 weeks out, we want to make sure that their bite's looking good. We want to make sure and see if there's any reason to titrate them or move the jaw forward anymore. Or maybe it's time for us to send them off to get a testing done to make sure that that number that they were diagnosed with, as far as how many times they stopped breathing, has significantly improved with the oral appliance. So this is the time when you'll make some of that little decision tree. This appointment, probably no more than 15 minutes, is how much shared time you're probably going to utilize with your patients. And then once that's done and it's determined that yes, the patient's well, yes, the device is working, yes, the physician's happy with the outcomes, then you still want to keep the patient on at least a 6-month recall. And the reason for that is to make sure that there's no negative changes or effects taking place as a result of utilizing the device. So you want to definitely have some form of a recall system built in. Now, what I went over is basically written in a different journal, Sleep Review Magazine. If you go to the hyperlink, or better yet, if you just go to Sleep Review Magazine and put in my name, there's an article that was written specifically on looking at every team member's role when it came to dental sleep medicine. So I think it's something that you should maybe just review if you're looking at incorporating this into your practice, but you'll see that you already have the key members in your team that are already there as far as your dental practice is concerned. What might be necessary is a little bit of education and a little bit of understanding of how this flow may look like. This is Dental Writer, as I mentioned, where you can get information for billing, but also at dentalwriter.com, there's a product that will actually allow you to capture this information for you to be able to generate the necessary paperwork, forms, and claims for medical billing. Additional to that, there's a series of courses that they actually do offer. I do lecture on their behalf along with other faculty members. We have an implementation course, which is a good beginner's course on dental sleep medicine in Los Angeles on May 4th and 5th. But if that's a date that you can make, if you just go to nearmanpm.com, you can look at the entire year schedule and see a course that might be closer or more convenient for you. I do encourage you to get some education. The idea for the education is to be a little bit more thorough in what I actually summarize for you. I need you to be aware of the types of appliances that are out there, which we did not have a chance to discuss, but most importantly, how to get that bite. Impressions you're all good with. I talked to you about my big favorite product in the office, and also the bite registration and the bite material that we utilize to capture that, once again being the Catapult product line. Now, I'll open this up to any questions that anybody might have, and be happy to take questions and answer them or guide you in any specific way that I can. Okay, so there's one question here in regards to what I said as far as the exam forms and the intake forms. There is a company, dentalwriter.com or nearmanpm.com, practice management. If you Google them and go to their website, you can see a software product that is something that we utilize and actually is our workhorse, where we have patients fill out their intake sheets and then we do our clinical exam, and the software encompasses both the patient portion and the clinical exam and generates a SOAP format narrative both for your referrals as well as for your record keeping, and most important to submit with the claim form to their health insurance to get reimbursement for it. I do at times use Gladwell Dental Labs. I do use a series of other labs. Any lab that actually utilizes or fabricates oral appliances can give you some guidance. I like to try and use a lab that has a series of different devices and not limited to a few. And the reason for that primarily is for the fact of being able to facilitate choices without me having to use multiple labs to get devices made. Now, if anybody has any specific questions on Catapult products, please write this down. Contact 877-532-2123. Great team of individuals, great team of knowledgeable, experienced professionals that will help you with the products, with the materials, and also all the other products and materials that they actually do provide for your services. So do take that into consideration, contacting 877-532-2123. There's another question about, is there any particular type or brand of mandibular advancement devices? And to be frank with you, there's well over 80 plus FDA approved appliances for the utilization of obstructive sleep apnea. What you'll find is a lot of practitioners will have their favorites. So, you know, I always get that question asked, what's my favorites? So my favorites are the Narval by ResMed, the True Function from True Functional Dental Lab, which is the True Function Herbst, and the True Functional Dorsal Appliance, followed by the Dream Tap. And True Function, in this case, makes all those devices, so I just have one place to ship them to and one place for me to pick the device that I feel fit for the patient. So does anybody benefit from, does someone with severe obstructive sleep apnea benefit from an oral appliance compared to CPAP? And that's a very, very good question. So let me give you my scenario, and you're going to hear this different ways. So ideally, I try and keep everybody on CPAP, believe it or not. My goal is to try and keep them on CPAP therapy for one major reason. We know that CPAP therapy is 100% effective. But guess what the problem is? There's a good 40 to 60% dropout rate with CPAP therapy. So those patients that are not able to tolerate it, whether they be mild, moderate, or severe, need to be given a second option. And at that point, it's not a bad fit to try an oral appliance in patients that may have severe obstructive sleep apnea, because in this instance, something is definitely better than nothing. So yes, we probably see more moderate and moderate to severe patients in our practice than I see the mild, but that doesn't mean that we can't treat them. But I always encourage them to at least give their best when it comes to CPAP therapy before considering oral appliance. What about tongue advancement devices? What do I say about that? I like to use it. I do like to use it in two scenarios. Scenario number one is when someone's edentulous and has a diagnosis of apnea. If I'm not able to use their dentures to bring the lower jaw forward because of poor ridges, then I may be forced to use a tongue retaining or tongue advancement device. The other time I may utilize it is as a temporary device. A good example is a patient happens to have a device that broke, and you need to send it back into the laboratory, but they're not going to leave without something, because I mean they need to have something to benefit their apnea. So those instances, we have tongue advancement devices on the shelf. We find the one that's the right size for them and let them wear it temporarily. Not too many major issues with tongue advancement devices, except for the fact that there is not a high favorable acceptance of it. Some people will complain of tongue-related issues the next morning, numbness, soreness, things of that sort. So it's not always utilized, but still definitely a good option to have. So same lead, I have another question saying, I have sleep apnea, moderate severe, and my Aveeno device works well and prevents bruxism. And that's true. The Aveeno device is basically a tongue retaining device. It brings the lower jaw forward. The Aveeno device is basically purchased through Glidewell Dental Laboratories. But there again, whatever works, whatever works as far as getting patients to feel better, but more importantly, being able to manage their chief complaints. Yeah, Monica has a wonderful question, and this is unfortunately a good loaded question, but I'll sum it up. How would you treat young kids whose parents report snoring? And this is a very, very, very good question. The problem with snoring in pediatrics is we really don't know, is it nasal congestion, is it due to tonsillar tissue, and as a result of the snoring, is there any cessation of breathing that may take place? Now I'm going to bring you up to speed. If we find an adult patient and we need to diagnose them with having obstructive sleep events, the guidelines are they need to stop breathing at least 5 times per hour to have a diagnosis of some form of apnea. Whereas in pediatrics, it's just 1 event per hour. So if a kid stops breathing more than 1 time per hour during sleep, it's a problem. How do we address the kids? Well, if they're snoring, what you first need to determine is do they or don't they have an apneic event, which means a sleep study is warranted. If the sleep study comes back negative, then the snoring can be addressed from one of several factors, whether it's tonsil tissue, adenoid tissue, allergies, and things of that sort. But majority of the time, you might find that they'll actually come back positive with having apnea. And this is where you have a crossroad decision. Depending on the age, one choice can be palatal expansion. If they're retrognathic, bring the mandible forward. And what you're noticing is we're trying to avoid extractions because we don't want to make that arches any smaller. And in some cases, it is also a combination of not just expanding the palate and bring the mandible forward, but possibly also removing the adenoids and tonsillar tissue to open up the airway. So my daughter was a sufferer. You know, it sucks when your own family has conditions that you treat on a day in, day out basis. But we had her evaluated at the age of 3, had a sleep study done. At the age of 5, we had adenoids, tonsils out, and snoring was no longer an issue for her. How do you know what device is best to start with? And this is from Thomas. Actually, Thomas, I'll be frank with you, my friend, there's really no which is the best one. I'd say just get comfortable with a few devices and just understand how the devices work ultimately. And you'll find that you'll have, based on clinical situations and scenarios, such as you have someone that is a significant broadser but has good, adequate clinical contours on their teeth. Well, here's a choice of possibly using a nylon type device like a Naval or a Panthera, because the likelihood of breakage is very nominal in severe bruxes. On the other hand, you may have someone that has a big tongue, scalloping, of course, and you want to try and avoid a device that has too much material that will take away tongue space. So here's a device where you might use a Herbst. You might even consider using a tap type device, preferably the newer design, the Dream Tap, to try and facilitate what your clinical picture might look like. And I'll be frank with you, Thomas, the only way you're going to learn is to make mistakes. And we all have made mistakes, and you'll learn from your mistakes and hopefully not repeat it. The good thing is if you made a mistake with oral appliances, you can always switch the patient out into another if it was due to poor choice. But very rarely do you have to switch patients from device to device. It's just a matter of fitting a device that's comfortable for them, where they'll be cooperative with it. And the key is to titrate, move it forward to a point that you address the subjective complaints, and then validate that you've done a good job by getting them objectively tested by their physician. Sam has a good question too. Oh my God, this is going to be a sleep course, it seems like. Sam's question here is, how accurate are home sleep tests? So I need to rewind a lot, and let me go back to sleep studies. When we have an in-lab study where a patient goes into a facility, they hooked up to about 16 to 18 leads. A couple of those leads actually go to the brain. The reason it goes to the brain is to look at the arousal phenomena I had mentioned. Now, an arousal, and if you look at the definitions of sleep apnea is a 90% or greater reduction in airflow with a 3 or a 4% change in oxygen, followed by a cortical arousal or brain arousal. There's another word I'm going to use here called hypopnea. Hypopnea is a 30% or greater reduction in airflow, followed by a desaturation and or an arousal. So those are the definitions. An arousal means the brain's waking up. Then an in-lab study will pick up not just the respiratory conditions associated with it, but also the brain aspects associated with it, giving you a much more accurate number. Home sleep testing only checks the respiratory parameters because there's no leads that go to the brain to look for arousals. So home sleep tests typically will underscore value than an in-lab study does. So they're not as accurate, but they are being utilized a lot more because of insurances not approving in-lab studies, so therefore physicians are forced to use home sleep tests. But if you're using a home sleep test for diagnosis, you're just hoping that the person tests positive, you do your thing, a home sleep test is repeated, and we just want to make sure that the numbers have improved. So I hope that sums it up. There's a little bit more to it, but that kind of just gives you a good synopsis of home sleep testing. Thank you, everybody.